Hello, Audio Medical Basics, Breakfast, Quick Answers book. We'll continue third subject from Quick Answers book. So today, Acanthamoeba infections. Acanthamoeba infections, key features. Essentials of diagnosis. Acute meningoencephalitis or chronic granulomatous encephalitis after contact with warm, fresh water. Keratitis, particularly in contact lens users. So two things, you have an Acanthamoeba infections, acute meningoencephalitis or chronic granulomatous encephalitis after contact with warm fresh water, or keratitis, particularly in contact lens users. General considerations. Free-living amoebas of the genus Acanthamoeba. They are found in soil and in fresh, brackish water. Granulomatous amebic encephalitis. It is caused by Acanthamoeba species and Balamuthia mandrillaris. More chronic than primary amebic meningoencephalitis, and neurologic disease may be preceded by skin lesions, including ulcers and nodules, and it develops slowly after an uncertain incubation period. Then we have the keratitis caused by the Acanthamoeba. It is painful, sight-threatening corneal infection associated with corneal trauma, most commonly after use of contact lenses and contaminated saline solution. So just keep in mind, we're talking about Acanthamoeba and we're talking about two diseases here at once, because all caused by this little nasty Acanthamoeba. Clinical findings. So first, the signs and symptoms of granulomatous amoebic encephalitis: headache, meningismus, nausea and vomiting, lethargy, low-grade fevers, focal neurologic findings, mental status abnormalities. Then the signs and symptoms of keratitis caused by Acanthamoeba progresses slowly with waxing and waning clinical findings over months. Severe eye pain, photophobia, tearing and blurred vision. Differential diagnosis. Many cases of Acanthamoeba keratitis are misdiagnosed as viral keratitis. Diagnosis. Laboratory test in granulomatous amoebic encephalitis. The cerebrospinal fluid shows lymphocytic pleocytosis with elevated protein levels, amoebas not typically seen. Diagnosis can be made by biopsy of skin or brain lesions. Lumbar puncture is dangerous due to increased intracranial pressure. So that's the laboratory test in case of diagnosis in granulomatous amoebic encephalitis. Diagnosis in case of keratitis. The keratitis. Lack of response to antibacterial, antifungal, and antiviral topical treatments and potential use of contaminated contact lens solution are suggestive of the diagnosis. Ocular examination shows corneal ring infiltrates, but these can also be caused by other pathogens. Diagnosis can be made by examination or culture of corneal scrapings. Available diagnostic techniques include examination of a wet preparation for cysts and motile trophozoites, examination of stained specimens, evaluation with immunofluorescent reagents, culture of organisms, and polymerase chain reaction. Imaging studies, CT and MRI, show single or multiple non-specific lesions in patients with encephalitis. So next, treatment, medications. In case of granulomatous amoebic encephalitis, some patients have been treated successfully with various combinations of flucytosine, pentamidine, fluconazole or itraconazole, sulfadiazine, trimethoprim, Trimethoprim sulfametha.
Trimethoprim sulfamethoxazole, trimethoprim sulfamethoxazole,
Trimethoprim sulfamethoxazole. Azithromycin. So, treatment in case of keratitis can be cured with local therapy, topical propamidine, isethionate, topical propamidine, isethionate, 0.1%, chlorhexidine, digluconate, 0.02%, polyhexamethylene, biguanide, and neomycin, polymyxine, beta-gramicidine, muconazole, and combinations of these agents have been used successfully in case of keratitis. Oral itraconazole or ketoconazole can be added for deep keratitis. Drug resistance has been reported. The use of corticosteroid therapy is controversial. Therapeutic procedures. Debridement and penetrating keratoplasty have been performed in addition to medical therapy. Corneal grafting can be done after the amoebic infection has been eradicated. Corneal grafting can be done after the amoebic infection has been eradicated. Outcome. Next come the outcome. Prognosis. With early treatment, many patients can expect cure and a good visual result. Untreated encephalitis can lead to death in weeks to months. In case of encephalitis, untreated encephalitis can lead to death in weeks to months. Untreated keratitis can progress slowly over months and can lead to blindness. So, prevention of keratitis requires immersion of contact lenses in disinfectant solutions or heat sterilization. Lenses should not be cleaned in homemade saline solutions. Lenses should not be worn while swimming. Thank you very much for watching. And this is all for Acanthamoeba infections. And this is all for the Quick Answers book. And next, inshallah, we might try something new. But for now, we might go back to the cycles. We might go back to the case files. Already made some videos for the case files to post. Well, even before I did this, but we'll see, inshallah. So thank you very much for watching, and thank you very much for sticking around. And please take care and see you all in the next